ask you guys to go ahead and take your seat, and we may get ready to get started. I'm Dr. Rachel Bussey. I'm the Director of Integrative Medicine here at Norton Suburban. I'm a family physician at Norton Community Medical Associates in the Highlands as well. I apologize for my lack of a voice today. I actually feel better than I sound. But I first wanted to thank you all for being here. We look forward to this coming hour for the opportunity to hear from Dr. Guarneri and take some of that vision and holistic approach and apply it here in our community. As you all are aware, there's also the opportunity to meet with different integrative practitioners and experience some of what we're talking about in the rooms next door, so we invite you to stay after and enjoy that as well. It is my pleasure to introduce Dr. Mimi Guarneri. She is an integrative cardiologist out in San Diego, California. She has, as she'll probably talk with you about, she has a background initially in interventional cardiology, and then over time came to look for a different approach with her patients. She founded the Scripps Center for Integrative Medicine, and she has spoken and written widely on the subject. She also is the president of the American Board of Integrative Holistic Medicine, so it's a very exciting time for our specialty as we build a full academy and make it a truly board-certified specialty. So without further ado, I'd like to introduce Dr. Guarneri. We're so pleased she's here.
Thank you. Thank you. Good morning. Okay, how are we for sound? Are we okay? Great. Now let's see how we are for slides. Who was at last night's talk? Well, you guys already know all this. Okay. And yesterday, right? Yeah. So I shared with you last night that I began my career here in the cardiac cath lab, and I know there's at least one former cath lab nurse in the audience. And I never asked a simple question in the 1990s, why does someone who has this blockage in their saphenous vein graft, who's already had a bypass, why are they in just somewhere between 3 and 5 years later with new blockage in their artery? I never asked that question. In the 90s, all I was asking was, should I put a stent in? Should I use a drill? Should I use a balloon? Should I use an atherectomy catheter? These were our tools in the toolbox in the 90s. And this is one of the miracles of modern medicine, the ability to stent a coronary artery and restore blood flow to the heart. But the learning for me came in recognizing that I'm not curing cardiovascular disease. That despite the fact that we do about 448,000 bypasses a year and over 1 million stents, that we're not really curing cardiovascular disease. We're doing a mechanical fix in an acute situation. Really, the cure requires getting to the underlying cause and reversing the process. And it's a very different way of thinking. So these are the statistics we have. We have about 42 million women living with cardiovascular disease. 1 out of 6 deaths, 2,200 Americans a day. So even though we're doing better, we're far from perfect. And if you look at the entire world, we rank #1 for obesity, #1 for diabetes, and #2 for cardiovascular disease. So we have a little bit of catching up to do. So I lived in the world of conventional Western medicine for many, many years. And it's a good world when you have an emergency. You have a heart attack, you have a stroke, you get hit with a truck. You want to be in the best trauma center, medical center that you can be in. But after many years, I realized I wasn't trained to do 2 things. 1, prevent disease in the first place. I really had no training in prevention. And 2, my way of thinking about chronic disease coming out of the acute care world was very skewed. What do I mean by that? When you're in the acute care world, who's in the emergency room here? Anybody? Any ER people? 1? So when you're in the acute care world, someone comes in and they say, I have chest pain. So the first thing that's going on in your head is Is the chest pain a heart attack? Is it an aortic dissection? Is it a blood clot to the lung? Or is it something less troublesome like indigestion? But you are doing what we call triage. You're thinking very quickly. You ask a few more questions. You come up with a diagnosis, and you say, okay, we're going to the cath lab. We're going to give TPA. We're going to do a CT scan, whatever it is, right? That's how you think in the acute care setting. So now if you take that way of thinking to chronic disease, you go to the ill to the pill, right? You say, oh, I have diabetes, here's your diabetes medicine. You have high blood pressure, here's your high blood pressure medicine. You're depressed, here's you guys following me? Here's your antidepressant medicine. And that's where I think we got into trouble. So in 2009, the World Economic Forum said that greatest global economic threat we have is chronic disease. And you're seeing it already in this country because we're basically saying we can't afford it anymore. Now, you guys know where you're sitting on this map. And, all these red states here have greater than 25% of the population that's meeting the definition of obesity. And then we have this strip here, which is getting into a little bit more trouble, greater than 30% of the population. And then you have Colorado, who is really doing the best, but now that they are all going to have the munchies, that may change. So I just guess we have to wait and see what happens in Colorado. And my state of California, well, we should be doing better. We're an outdoor state. We're outside all the time. We're active. We have good weather. We have no excuse for this. So for those of you in practice, doesn't matter what kind of practice you're doing, whether you're an acupuncturist, whether you're an internist, an RN, a cardiologist, doesn't matter. There's a good chance you're going to see patients that have one of these. So the reason we're getting into a lot of trouble is this concept of being overweight is leading to heart disease, diabetes, loss of muscle, sleep apnea. You see any patients with this stuff? Arthritis, fatty liver, osteoporosis, polycystic ovarian syndrome, erectile dysfunction, high blood pressure, lipids. This is really the bread and butter of what most of us treat every day in practice. And again, you can take the approach and say, well, I'm going to give a beta blocker, I'm going to give a statin, I'm going to give an ACE inhibitor, I'm going to give Cialis, I'm going to give, Fosfomax, I'm going to give something for arthritis, we'll put on our CPAP at night, take some metformin and call it a day. That is one approach. And it's an approach that's costing us now $2.5 trillion. And more to come. So we're spending an annual cost of about $500 billion on prediabetes and diabetes alone. And can we all agree that diabetes is preventable? I mean, I don't mean the kind of diabetes that if your pancreas fails because you have antibodies to your pancreas and you're a young person and that's a different diabetes from the diabetes that's lifestyle related, right? So we have 26 million Americans with type 2 diabetes, and 32% of our children are obese, with the CDC telling us 1 out of 3 children born in the year 2000 will be diabetic. So this is sort of, as a healthcare group, this is our call to action, right? How do we deal with this? And why is it affecting the heart so much? Well, we know that the weight that we carry in our midline, it's called visceral fat. This is the fat that surrounds the organs. The bad news is you cannot take it out with liposuction, okay? And this has been studied. It doesn't work. So this fat that surrounds the organs is called VAT, visceral adipose tissue. And it's very different from the fat that is subcutaneous. And the reason it's different is it is an endocrine organ in and of itself. So just carrying that extra weight produces angiotensin II, which raises your blood pressure, tumor necrosis factor, interleukin-6, CRP, which all lead to inflammation. So how does inflammation manifest in the physical body? What do people complain of? I have arthritis. My joints and my hands hurt. I'm losing my memory. I have cardiovascular disease. All of this is linked to inflammation. So when it comes to the heart, we know that every step along the way in plaque formation, from oxidized LDL to the recruitment of macrophages, white cells into the subendothelial space, it is all linked to inflammation. So in functional medicine, when we teach the cardiovascular module for IFM, we teach it this way. There's an infinite number of insults on the lining of the blood vessel. It can be a lot of things. It can be microbial. It could be what you're eating. It can be environmental toxins, blood pressure. Any number of these things can damage the lining of the blood vessel. But at the end of the day, it's inflammation, oxidative stress, and the immune response that ultimately leads to vessel damage. And this is why inflammation, to me, as a cardiologist, is one of the key ingredients. We say we have to turn the fire off, right? One of the key steps we have to do. And the more inflamed you are, the more oxidative stress you are. Now, you might say, what's this immune response? Cardiology is just sort of at the tipping point of starting to understand the role of toxins in cardiovascular disease. For example, mercury, cadmium, and lead lead to vascular disease. And yet, most people are not even testing for those things. Mercury is linked to atrial fibrillation, for example. Cadmium is linked to renal insufficiency. So, and there are microbes which are involved as well. And you'll hear more about that as time goes on. So I showed this slide last night, and I'll run through it quickly. But when we think about getting to the underlying cause of any so-called dis-ease, we have to think of exposure to toxins and chemicals, like I just said, mercury, persistent organic pollutants, pesticides, are linked to diabetes. Now I'm going to tell you a little secret. Remember I showed you Kentucky in that orange strip? That same orange strip has the #1 use in the country of atrazine, which is a pesticide. So in the functional medicine community, we're looking at that and we're questioning whether some of the obesity we see here is related to something we call obesogens, which are induced by environmental toxins. Because if you take 2 people that are overweight, we know that those that are exposed to persistent organic pollutants like pesticides, and those that are not, the ones that are exposed to pesticides, have a higher risk of diabetes. Now, you won't hear too many physicians stand up and say that, but I invite you to look at the literature because it's real and it's there. So when we talk about eating foods organic, it's not that I'm saying the nutrient value is better. I want to clean out those pesticides and those herbicides as much as possible, particularly in this area. And you have the right to ask the question, are we using atrazine on our soil? You have the right to ask that question. So all of these things, whether it's stress, how do we respond to stress and tension? Are we angry? Are we a hothead? Are we physically inactive? Trauma is an important one, emotional trauma. Dr. Vince Folletti did a wonderful study with 18,000 patients in it. Has anyone heard of the ACE trial, Adverse Childhood Events trial? This is something that should be on everyone's intake questionnaire, right? And the reason why is this. He was running a weight loss clinic. And he would just have people come in once a week and he would give them a liquid drink to lose weight, Medifast. And a woman lost 160 odd pounds and then attempted to commit suicide. And this is Dr. Folletti's story as he tells it. He was astute enough to bring her in and say, I don't understand. You came here to decrease your weight. You had such huge success. You look terrific. And yet you try to commit suicide. I don't understand. And she said to him, I lost the weight, and I was by the photocopy machine at work, and a man came over to me and said, hey, you look pretty good. Maybe you and I need to go out. She said, I had been so sexually abused as a child that my weight was my protection from this trauma that I had. Think about that for a second. Think about that. He then called in 2 guys, big guys. And now his wheels are turning. And he said to them, what is this wait about? And he said, well, they said, we're correction officers. He said, when we walk down the hall of the prison facility, he said, we want everybody to know we're coming and get out of our way. So he started to realize that perhaps some of the things we see later in life, like using food to comfort, using alcohol to comfort, using IV drugs to escape the world, using drugs in general to escape, might be related to something that happened in someone's past. So he went and did the Adverse Childhood Events Study, which has 18,000 people in it from the Kaiser Permanente group. And you can go on PubMed, it's all there. And what he found was the more trauma you had as a child, parents fighting in the house, parents in jail, parents hitting each other, not only just you, right? You think about how does a child escape, the higher the risk of addictive behaviors later in life, right? I never learned this in medical school. I never look at my patients the same again after reading this literature, and it is well worth reading. So that's why trauma, this is emotional trauma, is here. And I don't have to tell you guys about smoking, and we'll talk about nutrition. So we know our genes are the tip of the iceberg. I think the most important place right now for genetics, at least in my practice, is pharmacogenetics. How do people metabolize certain drugs, right? Like Coumadin, statin therapy. It's also really good for diagnosing things like what is the genetic cause of someone's cardiomyopathy? Does someone have long QT syndrome? We're starting to understand in cardiology lots of things that we can determine with genetics. But at the end of the day, your genes are not your destiny, right? So if you have the gene for diabetes and you decide to sit behind the desk and eat, popcorn and potato chips and everything white that you can find, yes, you'll manifest the gene. And then you say, there, see, it's all about my genes. But if you go out and you're jogging every day and you're burning those calories and you're eating green leafy vegetables, you're not going to manifest that gene in the same way. Okay. So I showed this study last night, the Amish population. This was in the Archives of Internal Medicine. They carry the obesity gene, and the researchers concluded they're not obese because they walk 18,000 steps a day. Now I invite you to put a pedometer on. And take a look at how many steps a day you're taking. Maybe it's 3,000. Maybe it's 4,000. But your goal is to get it up to 10,000. So how do we begin to think differently? I used to just clean up the mess. People would have chest pain. We say, okay, let's put in a stent. Let's get them home. We really were doing very little in our cardiology practice to turn off the faucet. As a matter of fact, when I first started doing this work in the 90s, I had a number of colleagues come to me and say, what are you trying to do, put yourself out of business? Right? And I'd say, there's too much business. There'll always be business. Maybe our business needs to be keeping people well, right? So again, a different way of thinking. So how do we take someone like my patient Ron, who I shared with the group last night, and how do we start to apply the science of health to get someone back toward whole health? How do we do that? How do we do it from an evidence-based perspective? Take a guy who's had a bypass and an AICD, has diabetes, is wearing a CPAP, has gout, has fatty liver, has high blood pressure, hyperlipidemia, and start to restore them toward full health, right? How do you do that? So what's the first steps? Well, you guys know this. I mean, in any cardiology practice, we still do our diagnostic testing. We don't throw the baby out with the bathwater. And routine treadmill test is still, the ability to walk on a treadmill is still, and go for a certain number of meds, is still the #1 predictor of your cardiovascular outcome. If you can't get on that treadmill and get above 4 mets of exercise, we have some issues. So this is still a very valid test. But we have even more fancy tests. This was the scanner I put in at Scripps. And you could look for plaque, early signs of plaque, like calcium in someone's arteries. Have you guys seen these kind of scans before? Here's a perfect example of a guy who went and scanned himself in 93, 95, and 97, and every time he brought the scan back to his physician said, don't worry about it. Today, we wouldn't say that. Today we say, oh my God, we got to get your blood pressure under control, your cholesterol under control. This is an early sign of vascular disease. And we can do blood flow scans to the heart. We can even do angiograms with just an intravenous in today, you know, in the right setting, what's called CT angiograms. So technology is great, but it's one piece of the equation, right? So when you identify these things, what do? In a typical cardiology practice, we'll do a lot of what's called advanced testing. Of course, we want to know everyone's fasting insulin and blood sugar, their diabetes test, their A1C. We want to know all about their cholesterol. Then we look at what's called inflammatory markers, things like CRP, interleukin 6 and 8, LPPLA2, homocysteine, right? And GGT is a blood test that's actually a screen for toxins. So this is sort of the bread and butter cardiovascular evaluation. The other thing we do on everyone is a 25-hydroxy vitamin D, and I always screen people for heavy metals if they have evidence of vascular disease. So I'll do a screening blood mercury, urine for heavy metals, and then if they look like they have a problem, we'll do a provocation test. So we can do a lot of good lab tests. This is the fourth vital sign. It's the waist circumference. You know, when you go see a doctor, you have your pulse and your blood pressure and all of that. And we know that if you take what's called a waist to hip ratio in a man, if it's greater than 1, and in a woman, if it's greater than 0.85, that places them at the highest risk for cardiovascular event. So in the clinic, you have the opportunity to not only do your blood pressure and your pulse and your respiratory rate and your heart rate, you can do your waist circumference, which has very specific numbers attached to it, and they are ethnically based. A waist circumference in an Asian male is not the same as in a Caucasian male. All right? So you have to use the ethnic criteria. You could put people on the scale, but as we talked about last night, it's not as good as doing a body composition. You know, you can be the same weight on the scale, but like this gal has a lot of muscle, this one has a lot of fat. So this is what we called, and we talked about last night, skinny fat. So body composition is important. I use in my practice something called a bioimpedance analysis. And it's good because it gives a basal metabolic rate. Do you think we all burn the same amount of calories just sitting in this room? No way, right? And you'll find guys, because they have more muscle, tend to burn more calories. Women with thyroid problems tend to burn less. But it helps us to be able to calculate what people should be eating, how much volume of food. Also, of course, types of food. But it also gives us how much fat someone has, how much lean body mass and muscle they have. And the nice thing is you can follow this over time. And many times people will say to me, you know, the scale didn't change, but my clothes fit differently, right? And that's really about their muscle. And then we have this problem with my patient, Ron. He has a triglyceride level of 585. It should be less than 100. He has a good cholesterol of 38. It should be greater than 50. He's diabetic, and he's inflamed. His marker for inflammation is high. I will guarantee you most of the patients that are running around here have some combination of this, right? So what do we do for him? If you put that tape measure around him, you see for sure he makes the diagnosis of metabolic syndrome, which is in women a waist greater than 35 and men greater than 40. These are for Caucasians. A blood pressure of 130 over 85, fasting blood sugar greater than 100, triglycerides greater than 150, and the good cholesterol, the HDL or the happy cholesterol, is low. So that's how you make that diagnosis. You have 3 of those. So you go and you say, I'm going to treat all of these with a bunch of different drugs, and I'm going to give an ACE inhibitor for his blood pressure. I'm going to treat his cholesterol, his triglycerides, his diabetes, give him an aspirin, and maybe give him a beta blocker, and that's how we treat cardiovascular disease. And now, because you are now in the integrative medicine department, and this is an integrative medicine lecture, you're going to think differently. You're going to say, okay, this is what everybody does. This is bread and butter cardiology and internal medicine. But we're going to get to the underlying cause of this guy's problems. And we're going to restore him toward full health using some drugs, but using a much more lifestyle-based natural medicine approach. So what do we do? Well, InterHeart was a great study, came out in The Lancet in 2004. This is the largest cardiovascular study of importance, as far as I'm concerned, for us. InterHeart looked at what are the risks of people having a first heart attack, acute heart attack, and they defined various populations by ethnicity and geographic regions. Take a look at this. 262 centers in 52 countries were in InterHeart. The whole world was involved. Africa, Asia, Australia, Europe, Middle East, North and South America. Everybody was involved. This is what they found. 14,000 people. Conclusion, smoking, no surprise. Dyslipidemia, particularly looking at the ApoB-A1 ratio. High blood pressure, diabetes, obesity, what you're eating, your physical activity, how much alcohol you're consuming, and psychosocial factors account for 90% of the risk of a heart attack. So we have the answer. So let's just undo it, right? Let's just say, okay, we're going to deal with people's anxiety, depression, and social isolation. We're going to deal with their alcohol. We're going to get them moving. We're going to fix their diet. We're going to get them to lose weight, fix their diabetes, their blood pressure, and we're going to prevent heart attacks. The answer is already out there. But we haven't taken this science and put it into practice. And that's really my goal. So at the end of the day, we have to fix Ron's soil. So he has diabetes and high blood pressure and dyslipidemia, and it's very easy to go up and say, gee, I'm going to chop off all these disease branches and fruit, or you can say, I'm going to go into the soil and I'm going to fix all of the problems. So lifestyle becomes the intervention. Now, I want to clarify one thing, because a lot of people think integrative medicine is about tools in the toolbox. Oh, instead of taking a pill, I'm going to have acupuncture. Or instead of taking a drug, I'm going to take an herb. It's not about that. Those are tools in the toolbox. In my toolbox, I have Lipitor and I have red yeast rice. I have muscle relaxers and I have acupuncture. There's a time and place for everything. And you need to know when to use these tools. I had a patient call me last night. She said, Dr. Guarneri, I went wild. I said, what'd you do? She said, I went out with a bunch of friends. I drank, and I know I'm not supposed to. I'm not a drinker. I fell, and I broke 3 ribs. And she said, I'm embarrassed to tell you this. I said, well, okay. She said, I am in so much pain. I said, well, you're going to have, and they gave her something in the emergency room. It didn't work. I said, well, I'm going to give you some Vicodin, and you're going to come in tomorrow for some acupuncture. Right? I wasn't going to leave her last night with nothing. That's a time when I'm going to pick a powerful tool out of my toolbox and use it. You know, she can't breathe. She's got 3 broken ribs. Everything she does, she's in misery. Right? So it's about knowing when to use the tools. So let me show you an interesting research study that I didn't show the group yesterday. A very interesting group of people were asked to eat this meal. And this was in the Journal of Clinical Nutrition. And the meal consisted of Egg McMuffin, and I won't say from where, a sausage muffin sandwich, 2 hash browns. So it had 85 grams of carbohydrate, 51 grams of fat, and 32 grams of protein. And they consumed this meal over 15 minutes. And they said, what happens to their NF-kappa B? Okay, so nuclear factor kappa B sends a signal to the DNA, tells the DNA, make proteins that cause inflammation. Remember I said inflammation causes heart disease and Alzheimer's disease and dementia and arthritis? So that's what they were looking at. And so it looked like this. They ate this meal, and then they looked at NF-kappa B. NF-kappa B sends a signal to the genes to produce what we call inflammatory cytokines. You hear that expression, food is medicine, food is information, right? So this is food being information. This is what they found. This is the change in NF-kappa B binding activity. This is water over 3 hours. And this is after the meal. Look at this uptick here in NF-kappa B, and it stays up for 3 hours. Just in time for what? What happens at 3 to 4 hours? Get hungry again, right? You're ready for your next meal. So this is the scenario of food leading to chronic inflammation. So if this meal was green leafy vegetables and wild trout or wild salmon, you would not have this NF-kappa B upregulation. But if this meal is Cinnabons and all this other stuff, this is why we're seeing the chronic inflammation that we're seeing. There's something else I'd like to say, because you probably don't hear too much about this. Who's heard about aged glycation end products, AGE? So aged glycation end products, worth looking at on the internet, are you take a protein and you attach a sugar to it. You know the hemoglobin A1C, right? So that's a protein with a sugar attached to it. So that's how aged glycation end products work. The way we prepare food increases the aged glycation end products. So how does it look? It looks like this. If you take an egg and you poach it, the aged glycation end products are very low because you don't disrupt the yolk. If you take that same egg, you disrupt the yolk, and you scramble it, they go very, very high. If you decide you're going to boil chicken, they're going to be very low. But if you decide you're going to take your meat and throw it on the grill and let it get charred and black, they are extremely high. So I invite you to take a look at this, because what we're starting to see now is these end products are ending up in the lining of the subendothelial space, and they're causing vascular damage. And we think that even statins work by decreasing these aged glycation end products. And that's why we say statins are anti-inflammatory. So go on the internet, take a look at this, and look at different types of food preparation. I think it'll be very insightful for you. So back to this study, they found that 1 hour after the meal, up to 3 hours, the NF-kappa B was up, and the HSCRP also increased. That's another mark of inflammation. So food can lead to inflammation. What kinds of food? It's going to be all your white stuff, right? It's going to be your deep-fried stuff. It's going to be your processed. It's going to be sugar. This has been well vetted out. If you decide you're going to eat that can of sardines, you're going to produce proteins that are anti-inflammatory. If you decide you're going to eat something really high in corn and omega-6, it's going to be pro-inflammatory. And it's important because you have to look at your labels. When you look at you should probably buy nothing in a package. Just about nothing, right? Yeah. No package. And no can. And it's important why no can. I mean, I still have to sometimes get my tomato in can because can's aligned with BPA. Everyone's heard about that. And we're taking it out of baby food cans now, but it's still in our cans. And bisphenol A is a toxin. So we say eat whole foods. You know, do you have Whole Foods, the store here? That's why they named it Whole Foods. Is you really need to be eating the whole apple, the whole pear, the whole organic berries, the whole grains like the quinoa. So it really should be low mercury, sustainable fish, and so on. That's how we should be eating. Ideally, we're eating lots of this, lots of green leafy vegetables and low sugar fruits, small amounts of avocado and nuts. 70% reduction in death and recurrent events for cardiovascular patients with the Mediterranean diet, right? 70%. Journal of the American Medical Association, 3 years later, diets using non-hydrogenated fat, whole grains. Again, I said it last night. That means you can't roll your bread into a little ball. It's a real whole grain. As your main carbohydrate, fruits and vegetables and omega-3s can protect against heart disease. The acronym I use for omega-3s is SMASH. The S is wild salmon. The M is mackerel, Atlantic mackerel, if you like that. The A is anchovies, right? The other S is sardines. H is herring. But again, if you go to the website for Seafood Watch, seafoodwatch.org, they'll give you the list of sustainable fish, and it's updated all the time, that are low in mercury, if you're going to eat fish. That's the good omega-3s. Mediterranean diet reduces inflammation, lowers CRP, interleukin-6. Remember I showed you that slide with all those inflammatory cytokines coming out? All of that is reduced with the Mediterranean diet. What are you not getting in this diet? You're not getting deep-fried onion rings. You're not getting French fries. Right? You're getting kale, and you're getting broccoli, and you're getting small amount of avocado. You're getting nuts. You're getting whole grains. You're getting fresh fruit. You're not getting white hamburger buns. You're not getting power bars that are glorified candy bars. You're not getting white cereal, right? So it's not that complicated. We can just say, I'm going to cut that stuff out. And we have people who can guide you if you need, or your patients need, in this area. So the HALE study was a European study. They took older people. They said, what about these 70 to 90-year-olds? Let's get them to walk, throw out their cigarettes, 4 ounces of wine a day, Mediterranean diet, 50% lower rate of all-cause and cause-specific mortality. In the HALE study, they attributed the diet to a 60% reduction in cancer and cardiovascular disease. Again, we have the science. Then why are we feeding America buns and that are this big, right? It's a volume game too. And not only did we supersize it with high fructose corn syrup, trans fats, and partially hydrogenated oils. Why did we do that? The food industry has made us addicted. We are a bunch of addicts. Take a look at the movie Fed Up. You're going to see brain scans in there that show the brain lights up in the same way with sugar as it does with pleasure. We see it as pleasure, right? So we have to break that cycle. I'm not saying it's easy, but we have to figure out how can we do that. This is the HALE study again. Lack of adherence to this low-risk pattern attributed 60% risk of all deaths, 64% cardiovascular, 61% cardiovascular, 64% coronary artery disease, 60% cancer. Powerful medicine. I shared this last night. This was one of our research patients from the 90s. This is a blocked right coronary artery. This is decreased blood flow on a PET scan. This gentleman, for 1 year, was taught to be a low-fat vegetarian. He was taught to transform his stress through yoga and meditation. He was put in support groups where he can get the support that he needed. And he was asked to exercise every day. Research study. This was the Ornish study that we did in the 90s. And every week he had a hand in. I exercised, I did this, I didn't eat any animal products. Every day he had to click off what he did. It's good to have your patients be responsible, right? If you journal your food, for example, by the end of the day you go, oh my God, I can't believe I ate all that. This is him a year later. I think you can agree that this artery is no worse, it is better, and the blood flow is markedly better. This is coronary reversal. This is reversal of plaque. Now, some of my colleagues will say, oh, we could do that with statins. Just give him 80 milligrams of Lipitor. Well, what does 80 milligrams of Lipitor do for those 50 pounds that are hanging on you? Or your energy? Or your sense of well-being? Nothing. So the drugs are okay, but you also have to say, what is the end point? And the end point is ultimately, how does someone feel? What is the quality of their life? I mean, I know none of us probably want to live long if we're living in the ICU on a ventilator, right? It's about quality of life at the end of the day. So this is the PREDIMED study, which just came out in 2013, New England Journal of Medicine. They said, let's put people on a Mediterranean diet and let's randomize them to extra virgin olive oil or nuts. They get olive oil or they get nuts. And they said, we're going to look at extra virgin olive oil, nuts, or a controlled diet that just reduces their fat. Go on a low-fat diet. This is what they found. These patients already had high risk for cardiovascular disease. If they were supplemented with the extra virgin olive oil or the nuts, it reduced the incidence of cardiovascular events by 30%. Right? Again, good medicine. Now we're going to take it to the planet for a second, because we know that the planet is struggling health-wise. And the greenhouse gas emissions, majority come from coal and what we burn for our fuel and our electricity. And a big piece for the entire world comes from the agricultural industry, which basically translates into the more we utilize the agricultural industry in the way that we're doing right now, the more greenhouse gas emissions we're producing. So in this study, they took a look at what happens to greenhouse gas emissions, water consumption, which, by the way, is our most valuable resource. It's not oil, because we can't live without water. Energy consumption and agricultural land use. If you compare a Mediterranean diet here versus a standard American diet here, and you notice just going with more fruits and vegetables, eliminating the saturated fat in the beef, leads to less greenhouse gas emissions, less water consumption, less energy use, and less agricultural land use. So we're going to have to start thinking this way. And if nothing else, a call to go to meatless Mondays, or meatless Mondays and meatless Fridays, because it's good for the planet. Diabetes prevention program, an old study, but always worth mentioning. 3,000 women who had gestational diabetes. 45% were non-white, which is good because we tend to not have minorities in research studies. Women with gestational diabetes during pregnancy randomized to diet and exercise, medication versus placebo. Who did the best? Placebo, huh? Placebo can do well when it's done right. In this case, it was lifestyle. They said, let's look at 4 years who develops diabetes. This is the lifestyle group, this is the medication group, and that's the placebo. So the people who did the diet and exercise were the ones that were least likely to develop diabetes. So you have a study like this, big study, New England Journal of Medicine. I'm not showing you data from Journal of St. Elsewhere, right? This is our major medical journals. We should be having these programs everywhere. But we haven't figured out yet how to pay for diet and exercise. That is why we don't have it. It's changing a little. What happens with diabetes when we do some aerobic exercise and strength training? What happens to inflammatory markers? C-reactive protein goes down. Leptin goes down. Adiponectin, which helps move sugar into cells, goes up. So again, exercise, powerful medicine. Exercise also does one other thing. It raises brain-derived neurotrophic factors, so it is a treatment for depression. One of the first steps for depression should be getting someone in a group, because they won't do it on their own, to exercise. Last night I talked about the impact of exercise and weight on blood pressure. For every kilogram of weight we lose, we decrease blood pressure 1.6 millimeters of mercury. So when you start thinking about this patient of mine, you're thinking, okay, Ron, we need a Mediterranean low glycemic diet. We need a walking program in weight loss, right? We need a few supplements, which we'll talk about in a few minutes. So these are the benefits of exercise. You guys know those. So what causes triglycerides, the form of fat in the blood called triglycerides, to go up? Who knows? Well, stress will raise cholesterol. Yeah. What else? What kind of foods? Carbohydrate. It's carbohydrate. So triglycerides go up with simple carbs and all the white stuff. White bread, white rice, white pasta, cookies, cakes, candy, ice cream, fruit juice, Cheerios, granola. A lot of people think granola is healthy. Granola is sugar, right? Then you have your liquid calories, fruit juice, wine, and soda. Right? So Ron has 585 on his triglycerides. You know I'm going to clean out the liquid calories. I'm going to clean out the white stuff. And we're going to pick foods that are low on the glycemic index. And one of the best things you can give your patients is a handout of the glycemic index that says, eat these foods, avoid these foods. It's very helpful for people. We know that when the triglycerides go up, the good cholesterol goes down. So we know that if we get the triglycerides down, good cholesterol goes up, and what's called small dense LDL, very aggressive cholesterol particles, will go down when we get the triglycerides down. These are other causes of high triglycerides: being overweight, physically inactive, liquid calories, high carbohydrate diets. Thyroid is very important. If anyone has a cholesterol abnormality, it's important to check the thyroid. The thyroid level is down, cholesterol is high, triglycerides are high. And then there are medications like beta blockers, which can raise triglycerides. So even some of the things we do in medicine, you know, in premenopausal women, statins increase risk of diabetes, right? And many of my colleagues say, well, it's better to have a little diabetes and have a low cholesterol. I'm not so sure about that. This is an example of the difference in glycemic index, low versus high. I think there's no surprises here of what's high. Chips are a big one. A lot of people like chips. They, for some reason, are dipping chips. And I tell all my patients, dip cucumbers, dip baby carrots, dip broccoli, anything but chips. So we're going to treat those triglycerides, and we're going to use omega-3s. Why? Because they lower triglycerides 45%. So this is evidence-based supplementation. I have a guy with high triglycerides. I'm going to put him on a Mediterranean low glycemic index diet, and now I'm going to pick some supplements for him. So he's going to get some omega-3, decreases non-HDL cholesterol, and raises the good HDL, the good stuff, 9%. I may use niacin. Niacin is a B vitamin that lowers triglycerides and raises the good cholesterol, HDL. For every 1 milligram increase in HDL, we decrease risk in men 2%, women in 3%. So this is an example of where I might use niacin. HDL, HDL2B, is the good cholesterol that actually pulls plaque out of the vessel and returns it to the liver. Reverse cholesterol transport. It takes it out and brings it back. That's how we get reversal. And for those patients of mine that don't want to take a statin, you know, I have people that say, I'm not taking statin to lower my cholesterol. I might reach into my supplement toolbox and I might give them red yeast rice based on this study. This is a study that compared a statin called Zocor at 40 milligrams to red yeast rice, fish oil, and a Mediterranean diet with exercise. So let's see what happened here. So the people that had the Mediterranean diet with exercise versus the statin, LDL, bad cholesterol, 42% reduction here, 39% reduction here, about the same, right? As good as 40 milligrams of Zocor. That's pretty darn good. Look at the triglycerides, 29% reduction here, but only 9% reduction here. Statins don't lower triglycerides. We don't use them for that. Weight, 5 pounds off, 5.5% down here. Well, we know statins don't take weight off you, only 4% here. Safety, heartburn here, liver abnormalities here. Right? I'm not saying throw out the statins. All I'm saying is we have options and we need to know when and how to use them. And this is curcumin. This is in Diabetes Care from 2012, showing 500 milligrams twice a day, followed for 9 months, reductions in fasting blood sugar, reductions in hemoglobin A1C. And I'm building it this way because we started with a patient. And we said, what are we going to do with him? So we're going to get him on the Mediterranean low glycemic diet. We're going to get him on the right supplements. We're going to get him physically active. Acidophilus improves insulin sensitivity. And magnesium improves insulin resistance. This is Diabetes Care 2004. If you look at magnesium deficiency, the markers for inflammation go up. Insulin resistance leading to diabetes goes up. If you give magnesium, they go down. Great supplement. So now I'm doing evidence-based supplement guidance. You guys following me? All right. Now, Ron has a history of congestive heart failure, and we know that mortality in congestive heart failure is linked to low CoQ10 levels. You go to the emergency room, and everybody's very quick to measure something called a BNP to see how someone's heart failure is doing, when in this study, published in the Journal of the American College of Cardiology, showed that a low CoQ10 level was an independent predictor of mortality. Right? So you know I'm going to give him CoQ10. And a very big study just came out, 2013, called Q-Symbio, 420 patients, CoQ10, 300 milligrams a day. Check this out. Significant reduction in cardiovascular events, 14% versus 25% in the placebo. Reduction in mortality, 9% versus 17%. Reductions in heart failure admissions. All of my colleagues who argued with me for years about CoQ10, because the studies were small, are now giving their heart failure patients CoQ10. So we say disorders determine treatments, right? This is the way to think about lipids. You have to look at what's going on, and then you can pick your treatment based on what's going on. So I'll end with this concept again of stress because it's real and it affects our patients. Last night we talked about life-changing events like death of a spouse and divorce causing huge amount of stress. We talked about the impact of the stress hormones, make the platelets stickier, raise angiotensin, raise blood pressure, put weight on us, raise our cholesterol, cause arrhythmia, and raise our blood pressure. Stress does all of these things. Stress does a couple of other things too. Muscle spasm, headaches, irritable bowel syndrome, lots and lots of things that come from stress. Here's some interesting research. If we look at chronically high cortisol, people that are under stress chronically, we have accelerated aging. Take a look at poor President Obama. Has this guy aged? Holy cow, right? Impaired memory and learning. The research shows who here has ever been under stress and you couldn't remember what you were doing? Or you couldn't make a good decision? We all know this. Stress causes osteoporosis. For the nurses in the room, what happens when we give people steroids to their bones? What happens? Brittle bones, osteoporosis. Well, what is cortisol? It's a steroid. So stress causes osteoporosis. Just like those patients we give steroids to, they lose their muscle mass. When you give steroids to somebody, they come in, they have skinny arms, skinny legs, and a big belly, right? It's the same thing when we have high cortisol. Our immune function is impaired. We know that people, when they're under stress, do not respond to a simple flu vaccine. We know it takes them 40% longer to heal a simple wound, okay? And we put weight on around the midline, and our blood sugar goes up. So if you look at this, you say, gee, this sounds a lot like aging to me, doesn't it? My memory's off, my bones are brittle, I don't have as much muscle, I'm getting fat, and I'm becoming diabetic. Sounds like aging in this country. And I don't know about you, but in California, we have a lot of yoga instructors. You have some yoga instructors here? Do any of them look 20 years younger than they are? They're the exact opposite of this because they're living a very different life. Right? Anger. This is the most lethal emotion for the heart. The more angry you are, the higher your risk of cardiovascular death, right? And depression. The more depressed you are, the less likely you're going to do well. So for those of you that are in the hospital working, we should be screening our patients for depression. We should be screening them for anger. We should be looking at adverse childhood events, many of the things which we don't look at. Last night I talked about ways to enhance resiliency, everything from prayer to meditation to social support and community. And we talked about how stress is our response and our perception, right? And that's a good way to teach it to patients. And last night I showed you this study, 4-year follow-up study on meditation showing a 48% reduction in heart attack, stroke, and sudden death. So if this isn't good enough to recommend meditation to everyone, I don't know what is. So I'm going to end with a couple of other very common modalities that I use in my practice. I have a full-time acupuncturist in my practice. Why do I do it? Because there's huge data, for example, to support the use of acupuncture in certain conditions. Here's one for headache. People with chronic headache, 12 acupuncture treatments versus usual care. Headache scores with the acupuncture decreased 34%. So if I have somebody with muscle spasm, osteoarthritis of the knee, asthma, sinus problems, headaches, acupuncture is in my toolbox. In this study, 15% less medication use, 25% less office visits, 15% less sick days at work. Acupuncture for headaches. I can do a whole talk on acupuncture alone. So this is an example of where you say, okay, what's the evidence? Level 1 evidence for migraine headache, there's a supplement called Butterbur. Anyone ever heard of Butterbur? Level 1 evidence, Journal of Neurology, randomized controlled trials, Butterbur works for migraine headaches. Right? So we have this science of healing that we need to be applying to our patients. Inpatient services over at Abbott Northwestern Hospital. You guys have a great inpatient program here. Jeff Dusick is doing us a favor by collecting data. We need to do research. This is the inpatient service line pain scores of patients at Abbott Northwestern after integrative treatments. Cardiovascular ward, 52% reduction in their pain. Rehab, 53%, 67% reduction in women. Take a look at anxiety, 57% reduction in their anxiety on the cardiovascular floor. Now I have to tell you, if a cardiovascular patient is anxious, what happens to their blood pressure? What happens to their heart rate? Do they get more angina? I mean, the list is endless. And this is they have 46 people on the floors doing treatments on patients. Acupuncture, Reiki, healing touch, massage. It's beautiful medicine. This is a study we did in active Marines, and people said to us, you're crazy. How are you going to get these Marines to succumb to healing touch and guided imagery? And Camp Pendleton came to us. And so we published this in Military Medicine. In 2012, we did healing touch and guided imagery for PTSD. Psychiatrists sent us the active Marines with PTSD, and we randomized them. You get treatment, you get usual care. Everybody got usual care. We did 6 treatments, and we did it quickly because these guys were being deployed again. This is what we found. We followed the PTSD, PCL military score. We looked at depression, quality of life, and hostility as secondary endpoints. Check this out, healing touch and guided imagery. If you have a PTSD score of 10 to 20 points that change, it's considered significant. We had a 14-point drop in people getting healing touch and guided imagery. Beck Depression Index for depression. A score of 18 is significant for depression. Our guys dropped, and gals, from 26 to 16. This is without drugs. They knew the drugs weren't working in some of these guys and gals with PTSD, which is why they called us in the first place, and they said to me, what do you have in your toolbox? Can you bring it up to Camp Pendleton? I'm so proud of the VA right now because there are a couple of pilots happening in the VA which will be a game changer because the VA is stepping up, at least in West Los Angeles, and they're doing all of this. Healing touch, acupuncture, auricular acupuncture, guided imagery, everything it takes to getting a vet back toward full life, right? And that's really wonderful. So at the end of the day, when you think about your integrative approach, it's just common sense, right? You remember the old saying, keep it simple? You know, I don't have to tell you guys about getting people to quit smoking, achieving optimal weight, finding a path to getting people active again, getting people to sleep again, changing someone's diet, pulling out those pesticides and herbicides, especially in this region. We may use nutraceuticals, resiliency training to handle how you respond to stress and tension. If your response to stress and tension is, I'm going to eat this donut because I'm under stress, then you need a different response, right? Medication. There's a role for medication. Global healing traditions. One of the first things I encountered when I started the lifestyle change program in my cardiac patients is they would come and say, I can't exercise, Dr. Guarneri, my back hurts. I can't exercise, my knee hurts. I have elbow tendonitis. I have plantar fasciitis. That's why I put in the acupuncture program, right? And then I had all these women say to me they had urinary incontinence, so I put in the biofeedback program. And all these people with headaches. That's when I started to think biofeedback and acupuncture for headaches and nutrition, you know, migraines in particular for food sensitivities. So you look at the evidence and you say, how do I start to build a program, individual for someone, that gets them back toward full life, that may be a combination of all of these. It's never one size fits all. And I showed you a picture of Ron. He went from here to here. He is not an enigma. But he came 3 times a week into the program. So he had a place to go. We need to create a culture of health, right? And it needs to be a multidisciplinary team. It wasn't me. First and foremost, it was him. But when he came in 3 times a week, half the time I didn't even see him. I would just wave. He'd be with the exercise physiologist. He'd be in yoga and meditation class. He'd be in cooking school and with the nutritionist. That's the multidisciplinary team. And if he got anxious and upset, he'd be getting healing touch, right? So it takes a village, and the village is in this room. We all have something to contribute. It's no longer anymore about the MD. I really think as an MD, and especially as a specialist, I need to be on the back end. I need to be where you can access me when you need me, right? And I'm happy to be overlooking. But if he was seeing me in the office once every 3 to 6 months, he would have never gotten to this point, right? He needed the support. He needed the coming in 3 times a week, meeting with his group. We call the groups cohort. Meeting with his band of warriors, his new friends. Needed that support from his colleagues. It wasn't just about, oh, gee, I'm going to go and see my physician. So I thank you for your attention this morning. Thank you. Thank you.